And now, I'm gonna pass the mic to Security.
Hi everyone, I'm Sukriti. I'm a PGY1 in internal medicine. It's been my first week, so uh, it was a huge roller coaster. So it's always nice to come back to this space, which just makes me feel so safe. So looking forward to today's case. And if you guys have a case, please put it in the chat. And if not, one of us will present a case too.
Maybe Kirtan can introduce himself now.
Hello. So good morning, everyone. Hope you are doing well. And it's definitely a different VMR. We don't have our dear host Avi, but I am very assured of the fact that we have Maria here, Sukriti here, and we have all my dear friends Rafa, Gab, Valeria here. So I think it would be great opportunity to explore our own capabilities, how we highlight how this is the case. Anyone has a place to order, and if you already have backup cases, so no worries. So let's see how it goes. And now I would like to pass the mic to Gabriel. Maybe he can introduce himself.
Hi everyone, my name is Gabriel. I'm from Peru. Very excited to be here today with you guys. And I know we'll have a great case today. I popcorn to Valeria.
Hello everyone, I'm Vale, I'm from Peru, and today I'm going to be scribing. So please volunteer to discuss and to present the case. It's going to be great. And I think
Hi friends, as you see, it's a bit different. We don't have Robbie here, but we want to remind everybody that Saturday VMR is really special to us because it's dedicated to everyone who doesn't speak English as a first language. And we really want to highlight all of your voices through the chat. So it's like a team effort. We're going to have a case that, as for the moment, nobody has volunteered yet. But then once we hear the case, make sure to leave in the chat whatever you're thinking about. How do you think about the chief concern, or if you want to share a pearl with us, leave it through the chat, and then I'll call for your help, and then you can introduce yourself, where you're calling from, and teach us some medicine. So for the moment, we don't have a case. Oh, AMK has one. That's great. AMK, do you want to introduce yourself, even though I think you don't need any introduction whatsoever?
Hey everyone, Anne-Marie Cooper here. I am in the hospital today, but had some time, thankfully, to attend VMR. So super excited to present a case today and hear everyone's thoughts.
Woo, it's gonna be great. Vale, do you want to share your screen and we can start?
So this is a case of a 42-year-old male presenting with altered mental status who was sent from the oncology clinic. Had a history of a CVA a year prior. He had some residual aphasia and felt like a little bit discombobulated sometimes in the morning, but usually mental status would clear throughout the day. But for the past week, has been more confused throughout the day. The pregabalin was discontinued in the prior week due to concern that it was contributing. He was also diagnosed with a urinary tract infection and prescribed Keflex, but that did not help. He then developed bilateral facial twitching over the past 48 hours. The view of systems was negative for fever, chest pain, shortness of breath, nausea, vomiting, diarrhea, or constipation. Was seen by his oncologist.
Oh, I think we might have lost AMK for a little bit, but, or is it me? I'm not sure. Somebody move. All right, no, yeah.
Okay, it was me.
Let's see. So we have like this really good chief, like first history of past medical illness, and it's really interesting. We do have certain things here. I know that Robbie is thinking something really special, Venn diagramming, altered mental status, and the oncology clinic. Robbie, do you want to open up your mic and share with us what you're thinking?
Hi, good morning, everybody. I guess since it's international VMR, I'll speak a few other languages. So Hungarian is, I was in Hungary for a bit, so Jó reggelt kívánok is good morning in Hungary. And in French, comment ça va? And German, guten Morgen. I know Hans, I was out in Cologne and was a neighboring Dusseldorf, right? Dusseldorf, if Hans knows those two towns. Yeah, Kushal, yeah. What I was thinking, it's a patient that's coming to the oncology clinic, so there must be some background of an oncological issue, things that oncological patients may have. They may suffer from their malignancy, they may have a paraneoplastic effect. They could also have medication-associated issues. So if they're on chemotherapy, they're immunosuppressed. So infections are, top and foremost that we must think about. And then other things can be chemotherapy-associated complications. Sort of like PD-1 inhibitors can cause inflammation. So colitis is a big one. And I think there's other effects that sort of escaping my mind. So just a few things. Using that, somebody put up missed mnemonic. So missed mnemonic applies, but within a framework of cancer. But I think we lost AMK there.
Yeah, I think we lost her, but thank you for commenting on it. I think it's a great reflection. One of the things you can do for clinical reasoning is once you have like a chief concern, focusing on that. So in here, it's altered mental status. But as Robbie says, whenever something tips your balance off, for example, in this case that we have the oncologic clinic, you can narrow down that chief concern and make it more specific to your patient so that you're not applying the same altered mental status schema for everybody. Baseline rate of disease has to come into play. And like the baseline rate of this disease that is something oncological is very important. I know that Hans also has some thoughts on the chemotherapy and immunocompromised status from the patient. Hans, do you want to share it with us?
Yeah, I was thinking that if the patient is on chemo, maybe he has just came down with a very severe infection affecting his brain or his meninges, an encephalopathy, something like this. So a viral infection. And of course, it's, as mentioned before, it could be cancer related, some paraneoplastic, everything that's in the mist.
That is great. Always remind yourself of like the common causes of infections and then like the funky causes of infection. Kushal, do you want to share with us like some of the most funkiest infections you can think of? Kushal, are you there? You might not be there. And what are we thinking about? Oh, you're babysitting, no worries. Thank you for still being here and sharing us a lot of pearls through the chat. And besides the altered mental status, I think something that like struck in our minds, it was the facial twitching. Gabrielle, do you want to share with us what do you think about the facial twitching, or like if you have a schema for it, or what you're thinking?
I certainly don't have a schema for facial twitching, but linking with a Wednesday's case discussing with Saben, we have to think about the principal causes of facial twitching, and one of the main discussed topics on Wednesday was hypocalcemia. And maybe this hypocalcemia that could be presented in this patient could be explained by one of the most common oncology emergencies that we have to keep in mind as a non-missing differential diagnosis, that is tumor lysis syndrome. In this condition, the patients present with hyperkalemia, hyperphosphatemia, and hyperuricemia, but actually the calcium, it decreases.
Yeah, I think that is a really interesting thought, and we definitely want to keep it in mind when we see like the labs. So I'll share with you one of my favorite schemas, and it's actually like a combination of like Reza's mind and Aaron's mind. So it's like Venn diagramming the neurological complications of systemic cancer. And as Robbie masterfully stated, and Hans also suggested, you can have like direct involvement, like through metastasis, local spread. And I don't think we know like what is like the cancer, like that this patient has, but definitely some cancers are more prone to like CNS metastasis than others. We also have like the hypercoagulability, which strokes can be a cause of altered mental status, and cancer as itself is a hypercoagulable state. If you haven't heard, the Curious Clinicians have a really good podcast as to why this happens. And we also have like the complications of the treatment, is it chemotherapy or radiation, or even like the fancy inhibitors that, they have like 1,000 names and for every single checkpoint marker, but then, always Google search, what the patient has, like what's his treatment and what are the complications of that treatment. Google is going to be your best friend for that. And there are also a lot of paraneoplastic syndromes, as you've mentioned. Let's remind ourselves that, antibody-mediated encephalitis, it's like this huge growing category in neurologic disorders, and they might be paraneoplastic or they might not be paraneoplastic, but definitely in the context of a patient who already has a cancer diagnosis, think about paraneoplastic causes. So AMK, I see that you're back. Oh no, I don't see her anymore. I saw her just like a couple minutes ago.
I am back. I like lost my computer, rebooted, and I'm trying to, it's being difficult. So I'm like trying to still find the case right now. I don't know what happened to it. Let's see. Can y'all just give me another minute? I'm so sorry.
No, don't worry. Yes, of course we can take all the time you need. And so, I don't know, we've discussed about like the neurological complications of systemic cancer. There's also metabolic complications of systemic cancer, as Gabrielle told us with the tumor lysis syndrome. Yes, Robbie, you read my mind because I was just thinking about that. Do you want to share like some of your pearls about neutropenic fever?
Yeah, I was just trying to remember what are the oncology. We always approach a problem with red flags. So what are the like red flags or life-threatening causes? So I remember in oncology, tumor lysis syndrome was a great one. Somebody, I think Gabrielle mentioned, but neutropenic fever is another one when your absolute neutrophil count is below 500, and then you're prone to having infections such as Pseudomonas. So empiric antibiotic therapy is key, especially coverage for Pseudomonas, and pan culturing the patient. And if there's no resolution to the infection, then you must think, I think within 72 hours, you must think fungal infections. Other oncology emergencies, I think also metastasis of the spine. So cord compression is another one. And there are a few other ones I'm sort of remembering.
Okay, I've gotten the document back up. So what I was finishing was seen by the oncologist 2 weeks prior, and there was concern for relapse of the disease. The patient had had Hodgkin lymphoma and had gotten bone marrow transplant 10 years prior, but had actually done really well since then and was not on active treatment or anything like that. Was presenting because they were planning to get a bone marrow biopsy, but then because of the altered mental status, they were sent to the emergency department for further evaluation. Past medical history includes type 2 diabetes, hypertension, OSA, the Hodgkin's lymphoma we discussed, and then the prior cerebrovascular accident 6 months prior, and then had also kind of as part of the stroke workup, had gotten metanephrines, which were elevated around 1,000, but had not been worked up since then. And then had had a negative hypercoagulability workup in the past. Medications include cephalexin, tizanidine, amlodipine, aspirin, atorvastatin, baclofen, clonazepam, clonidine, Cymbalta, spironolactone, topiramate, valsartan, and Ambien. Family history, non-contributory here, and then social history, no tobacco, alcohol, or drug use, and sexually active with their spouse.
Wow, this is all very interesting. Do you think this is a good moment to like stop, or do you want to go ahead and like give the physical exam and then we'll stop? What do you think?
I can go ahead and give the physical exam.
Okay.
Heart rate was 110. Respiratory rate was 20. Blood pressure was between 130s and 180 systolic and between 80 and 100s diastolic, and was saturating 100% on ambient air. Otherwise, as far as other exam, appeared chronically ill, able to follow commands, but was unable to answer questions. Oropharynx without erythema or exudates, was tachycardic on cardiovascular exam, but no murmurs were heard. The lungs were clear to auscultation with normal work of breathing. The abdominal exam was normal, no CVA tenderness, no edema of the extremities, and the extremities were warm. And then on skin exam, there were no rashes seen or lesions. And then as far as neuro exam, this was not a neuro exam that I did, but had aphasia, could understand yes, no questions,
no gross focal neurologic exams, had 4 out of 5 upper extremity strength bilaterally, and then 4 out of 5 lower extremity strength. And then normal patellar and biceps reflexes, cerebellar testing with the finger to nose was within normal limits, but sometimes twitching of the hands were noticed. Gait was not assessed. There was no facial droop. Their symmetric face, and otherwise the cranial nerves were intact.
Thank you, AMK. This case is awesome. And a lot of people in the chat have like great suggestions and great pearls. Tiago, would you mind unmuting your mic, and maybe you can do like I think this is a great time for us to summarize what we have for the case. I don't know if you mind doing that like in Portuguese. And there's this exam that is just calling your name, friend. Can you explain to us like what do you think about the elevated metanephrines?
Oh, sure. So, for the case in Portuguese, se trata de um homem de 42 anos com alteração do status mental e com uma história prévia de linfoma, e ele veio depois de uma visita à clínica de oncologia, e tem uma história de ter metanefrinas elevadas há mais de 10 anos, nesse momento com uma hipertensão lábil, mas ele consegue seguir comandos, apesar de não conseguir responder questões. And, for these metanephrines, it called my attention because it's not common for us to order metanephrines for our patients. So did someone suspect in the past that he could have pheochromocytoma? That's in my mind. Pheochromocytoma is known for a triad, but this triad is not common. The classic triad consists of headache, sweating, and tachycardia, but most patients, they don't have the classic triad. And, one other sign of pheochromocytoma is this paroxysmal elevations in blood pressure. So you see that the blood pressure is varying a lot. So with this past history of elevated metanephrines and now this blood pressure that is just varying a lot, it makes me think about pheo. Most times we think about pheo, it's not pheo because pheo is so rare. But in the recent years, with the more images being used in clinical practice, we see many adrenal incidentalomas, and then we have seen asymptomatic patients with pheochromocytoma. So it's very difficult to diagnose this rare disease because patients often do not have the classic triad, and there are many asymptomatic patients. But with this history of elevated metanephrines in the past, and now this labile hypertension, I would look to this point. And for the medication he uses, clonidine, it puts your catecholamines and metanephrines down, but not if you have a pheochromocytoma. So people who you can do this test. It's not done nowadays, but the clonidine suppression test, because if you have a high metanephrines, then you give clonidine and it goes down. But if you have pheochromocytoma, it does not go down. So I chose to make comments about pheochromocytoma because I feel more comfortable with that.
No, but that was amazing, masterly done. I even really like the part in Portuguese, even though I didn't understand half of it. But I think it was a weird test and it had to be commented on. And I really like the pearl about the clonidine. I actually never thought about it that way. And I think a lot of other people are also worried about this never-ending list of medications. Carl, you had really good thoughts. Do you want to share with us where you're calling from and what are you thinking about the meds?
Hey, yes, I'm calling from Denver, Colorado. Nice to be here. Yeah, just with somebody with this extensive of a centrally acting med list, common scenario, I feel like in the hospital, somebody is maybe like doing okay on stable doses of all these meds, but then gets an AKI, for example, or an acute liver injury for some other reason, and now has impaired clearance or altered metabolism, and then that is enough to make them floridly loopy.
Yes, you are right on track. I think, you know, always the list of meds, especially we were thinking about, you know, the side effects each medication can have, but also, you know, how they work with each other, you know, the additive effect of all of the medications, especially the centrally active ones. I think that's a great point. I think, let me look at it. Somebody else. Yeah, Nilayan, do you want to share what you were thinking about possibly I'm sorry, I can't read. I can't read names and talk at the same time, but Nilayan was thinking about, you know, psych emergencies like serotonin syndrome. What made you think about that? And do you still think of that way looking at the physical exam?
Yeah, hello, everyone. Yeah, I think the thought of serotonin syndrome was shared by Ravi. And I just thought that maybe serotonin syndrome and neuroleptic malignant syndrome both are very acute in origin. I visualize it as acute onset of fever, rigidity. Serotonin syndrome has typically myoclonus, and someone put it on Twitter as seroclonin syndrome just as a way to remember it. And that's how I remember it. And NMS has also hyperpyrexia, and apart from that, increased CK. So maybe muscle pain as well. So, and it's hyperacute in the face of the fact that the patient has a chronic history. Over the past few weeks, the patient had her altered mental status. So I think I would put that maybe lower in the list, and not that up high. And we do have metanephrines, and the discussion is certainly very interesting as to how can we marry pheochromocytoma with altered mental status. And I'm looking forward to it.
Great. I think those were really good hypotheses, and I think we're ready for AMK to give us a little bit more information, and then we can merge, you know, his past medical history, which we don't really know yet if, you know, his past diagnosis of cancer is really at play here, or is it just like a red herring? We have to merge that with the altered mental status, the polypharmacy, and the metanephrines. And yeah, AMK, do you want to share the case, a little bit more of the case with us?
I think the labs will be very revealing. So the CBC with differential showed a WBC of 9.8 with a normal differential. The hemoglobin was 6 with an MCV of 80, and the platelets were 10. Previously, about a week prior, the hemoglobin had been 10 and the platelets had been 28. The BMP showed a sodium of 143, a potassium of 3.5, a chloride of 109, a bicarbonate of 22, a BUN of 25, and a creatinine of 1.17 with a baseline creatinine around 1. The glucose was 279. And the calcium was normal, as was the magnesium level. The hepatic function panel showed a normal albumin and a normal total protein level without a gamma gap. And then the total bilirubin was 2.9. The AST was 51. The ALT was 16, and then the alkaline phosphatase was within normal limits. Also had a mildly elevated troponin at 0.426.
Awesome, AMK. Do you have the times, the bleeding times, the TP and TTP, or TPP?
So the INR, APTT, and fibrinogen were all within the normal range.
Thank you. So what are we thinking? Very revealing labs, as AMK said. We now have a very worrisome anemia and thrombocytopenia and maybe acute renal failure. That's a really good triad for what Carl was thinking. Carl, do you want to share with us what were your thoughts?
Yeah, I feel like it's just the other day in a VMR case where I was like banking on TTP as the diagnosis. So here we are again. But this is actually a kind of worrisome picture for that. Principally, we've got this acute drop in hemoglobin and platelets. And when those two cell lines are down together with the relatively normal white count, that raises our collective concern for one of the MAHAs, the microangiopathic hemolytic anemias. The elevated T-bili sort of with other LFTs normal definitely suggests potentially hemolysis as well. And then, as you guys know, CNS involvement can be part of TTP. So I think kind of how this changes my differential is maybe I take off or remove, sequelae of neutropenia because the patient's not neutropenic. So I'm less concerned about like an opportunistic infection. I'd still be worried about sort of the other things on our schema for systemic cancer and neuro. But now separately, I'm adding this TTP, this MAHA to our differential.
That is great. I will just quickly share. Keep putting in your thoughts in the chat. I just want to quickly share the schema for what Carl is thinking. Just let me find it. All right. Okay. So this is what we're thinking. Why are we thinking about hemolytic anemia? I have so many tabs open. I am so sorry. So we're thinking about hemolytic anemia, as he said, because of the worrisome anemia, and then we also had like elevated bilirubin. We didn't get like an LDH level that would also be high if we're thinking about hemolytic anemia. And every time you see hemolytic anemia, like reflectively go check the platelets, because if the platelets are abnormal, as in this case, then you have a really good case for microangiopathic hemolytic anemia. And then the three main causes we tend to think is like DIC, and then reflectively when you check for hemolytic anemia and you have thrombocytopenia, go ask for labs, and if the PT and PTT are high, then you got a really good case for DIC. If those are normal, then you can rule out a DIC. So PT and PTT are very important. And then we have two things that we tend to think about, TTP and HUS. And the HUS is typically has a story about like a diarrheal course, which we don't have here. And the TTP, it's the pathophysiology is an alteration in the atom TS13. So you have this very crazy going thrombogenic course, and then you have all of this microthrombi being provoked in the vasculature, and then that lyses the red blood cells. And that can be idiopathic, but that can also mean like a certain autoimmune disorders or even paraneoplastic. So and it has this penta that we already have 3, 4. We have the microangiopathic hemolytic anemia, the thrombocytopenia, the renal failure, the altered mental status, and there was one more that I can't remember. But as you see, this has a very good component of neuro and kidney disorders, which we're looking at. And then reflectively, we're thinking about TTP, HUS, PT and PTT are normal. What should we look for? Go ask for a smear. So if the smear comes back and you have schistocytes, then you really have a good case for MAHA, which is a hematological emergency. So I'll stop sharing my screen. I want to come back and see. Yes, Gabriel, do you want to share with you what you're thinking about the Coombs testing?
Yeah, I definitely want to do a peripheral blood smear, because in case we saw schistocytes, we want to think about firstly thrombocytopenic purpura. But if we don't, and maybe we could start thinking in acute hemolytic anemia. And one of the principal ways of diagnosing this condition is doing a Coombs test. Actually, acute hemolytic anemia is most commonly associated with not Hodgkin lymphoma, but it's also associated with Hodgkin lymphoma, but not very common, actually.
That's great. I think that this is where we can really talk about the past medical history, and Curtin actually has a really good hypothesis as to what can be happening with his previous history of the Hodgkin lymphoma. Curtin, you want to share it?
Yes, sure. So I am actually right along there with you. So Ravi, Carl, Gabriel all mentioned that we have to prioritize the TTP and HOS thing, because we know that MEHA can deteriorate so suddenly that the patient can die in front of you. So we need to get a smear, and if we find the evidence of cystocytes there, we can immediately start the plasma exchange, and we can give maybe even steroids to calm down the immune system. But what I was worried about, that sometimes you get the bone marrow involvement, and I am not sure whether the patient currently is on chemotherapy or not. Maybe we can ask AMK, and then she can share whether patient is currently on chemotherapy or not. And if he is not on, if he is not on chemotherapy, then what are the hypotheses? So one of the ways in which we can link Hodgkin lymphoma to everything is that we know that Hodgkin lymphoma can transform into DLBCL, that is the diffuse large B-cell lymphoma, something known as the Richter's transformation. And if that happens, then we can get hemophagocytic lymphohistiocytosis like picture. And usually in HLH, fibrinogen tends to be low. In this case, it doesn't fit well, but still it's something we have to consider whether bone marrow involvement is there or not. And whenever we are considering the relapse, I mean, in history, it says that 2 weeks prior, the oncologist was considering the relapse. And whenever we're considering the relapse, we have to get the CT scan of the abdomen and pelvis. We have to get the PET scan. We have to look whether lymph nodes are lighting up. And if nothing is revealing, then maybe go to bone marrow biopsy. And I guess bone marrow biopsy can reveal anything which we might be missing. So those are my thoughts, whether it is complication of Hodgkin's lymphoma itself or not.
That was amazing. Let's see what AMK has for us. Hopefully she'll give us a couple of what you wanted. Great.
Yeah, so no active chemotherapy had not been treated. It was considered cured after the bone marrow. As far as other labs, the LDH was 4,500. The haptoglobin was less than 20. The D-dimer was 2,200. And then the urinalysis showed some RBCs and WBCs. The retic count was 8.8%. And then the Coombs testing was negative. And the peripheral smear did show schistocytes. I'll leave it there. And that's the last aliquot.
Oh my God, I feel like I'm not ready to give away like the final diagnosis. I have no idea, but Ravi, aha maha, yes. Do you wanna tell us how you got to that conclusion with all this evidence?
I think you did a wonderful job with that slide, pointing out all the salient features, but I think the proof is in the labs. What AMK just put up there, the LDH is a massive number there. And it could come from tissue destruction, mainly with the anemia. I just imagine, you know, lysis of RBCs, haptoglobin less than 20 also points and supports the hypothesis that everybody nicely sort of came across. And then the retic count, the bone marrow is trying to compensate. And then you got schistocytes. So putting all that together with a mild creatinine elevation, altered mental status, I think we're fulfilling the criteria for TTP. Wouldn't you agree?
Agree completely, yes. TTP is always really strange for me because I feel like with a lot of the hem-onc diagnosis, even like getting there is just not getting me like far enough. Like I want to know like what is provoking this TTP, just as we do with like HLH, what is provoking this HLH? And yes, we'll see what AMK has for us. Tiago, do you want to read to us your Portuguese problem representation, and then we can wrap this up?
Oh, homem de 42 anos apresenta com alteração de estado mental nas últimas 48 horas. Tem história prévia de linfoma, não faz quimioterapia atual e trata diabetes e hipertensão.
Awesome. Carl, I see your question. We can let AMK finish and then maybe she will answer that question for us. Can TTP be a paraneoplastic phenomenon? I'll pass it on to AMK.
Yeah, so I think this is an interesting case to like calculate a plasmic score. So the plasmic score can help you kind of prioritize the risk of TTP. And if you calculate it, you can pull it up on MD-Calc. Platelet count less than 30 is a yes. Hemolysis is a yes. Active cancer, I would say no because it's not an active treatment, but does have a history. It's a history of solid organ or stem cell transplant, which is a risk factor for TTP, which is a yes. MCV less than 90, yes. INR less than 1.5, yes. And then creatinine less than 2 is a yes. So it comes back at 6, which is the high risk group, which has a 72% risk of severe ADAM-TS13 deficiency. So the ADAM-TS13 level did indeed come back less than 5%. Had kind of a complicated treatment course for things that I won't get into, but was started on steroids, TTP treatment, and actually did well, although later had a relapse. The thought behind why it could have occurred was actually related to the past malignancy and the stem cell transplant. And then the metanephrines was a little bit of a red herring that did not get worked up during the hospitalization and was planned to maybe be worked up after, but then I haven't seen kind of further of that. So that I cannot kind of say exactly kind of the further workup, what was the final kind of thought process on that. So that is the end of the case.
Wow, that was great. AMK, thank you for sharing so much. I've never heard of the score, but I'll just share my screen really quickly so that others can get familiarized with it. Plasmic score for PTT, and it's like right on Medscape. I love scores because it makes our lives so much easier. It's like it reminds us of all of the criteria for it, and then once you like get it, it validates your thought process, especially as a student with a lot of like imposter syndrome. Scores are my best friend. And it was a really good case, especially because it allowed us to think also about the metanephrines. And, you know, as clinicians, you really have to figure out that your input, like your thought process and how you consolidate the story, the baseline rate of disease, the clinical presentation is much more valuable than just a random test. So whenever you see a test come back, always think, you know, does this change my antenna, or does this change like what my thought process for this case? At the beginning, it did, like Tiago mentioned that, you know, it could explain his hypertension. And then once the labs came, you know, that wasn't compatible with like a pheochromocytoma. And then there's this much urgent process going on, which was the MAHA and the TTP. So always, you know, don't get carried away with labs, because labs, you know, as medicine advances, we're going to get more labs for anything, and then you really have to trust how you view the patient with everything together. So Rafa, you managed.
Hey Maria, can I give just a few more TTP teaching points really quickly?
Please go ahead.
So TTP and ADAM-TS13, it's a von Willebrand's factor cleaving protease, and deficiency leads to large multimers of von Willebrand's factor that increase the risk for small vessel thrombosis, which consumes the platelets and shares the RBCs. So the full tetrad is fever, MAHA, thrombocytopenia, AKI, and neurologic symptoms. But it's important to note that the full tetrad occurs in less than 10% of cases. It occurred kind of earlier in the when it was first characterized because treatment wasn't as good. And so definitely do not rely on the full tetrad being present. And renal manifestations are actually uncommon. And if they're present, they're usually mild and transient. In fact, we can see by plasmic scoring that one of the criteria is a creatinine less than 2, which actually increases the risk of TTP, because if it's greater, then you're thinking about a complemented mediated TMA or HUS syndrome if you have the compatible like schistocytes in a MAHA picture. If the plasmic score is greater or equal to 5, that definitely indicates sending ADAM TS13 testing. And then diagnostic is considered activity less than 10%. About a third of the causes are idiopathic, and about 2/3 of causes have an underlying precipitating factor, including pregnancy, malignancy, certain drugs can precipitate it, infections, autoimmune causes, as well as transplant is a precipitant, as we can see by the plasmic score giving a point for that. And you can also get an ADAM TS13 inhibitor. It's good to check an HIV because up to 20% of cases are HIV positive with TMA. And then don't wait for ADAM's TS13 testing because it's an emergency. So go ahead and start treatment. There's up to a 50 to 90% mortality without treatment. And then treat the underlying causes present. Generally, treatment includes plasma exchange, immunosuppression, obviously with usually with high dose corticosteroids first. And then there's also an antibody. This is fairly new. I'm going to mess up the name. It's called capitalizumab or something like that. Someone can correct me if I'm wrong. That is also sometimes given. So those are just kind of a few teaching points about TTP.
Thank you. We really, really, really appreciate all of your teaching points. They are amazing. So many things I didn't know about. Rafa, do you want to finish us up with also a list of amazing teaching points?
First, I just wanted to thank AMK, but also I really wanted to, maybe Gabriel can share a teaching point in Spanish that he enjoyed this session, and maybe Thiago in Portuguese.
A mí me encantó realmente el teaching points de Emery acerca del valor de la creatinina para el diagnóstico de la púrpura trombocitopénica trombótica, porque un valor menor de 2 actualmente realmente lo que hace es aumentar la probabilidad de púrpura trombocitopénica, porque si es mayor de 2 estaríamos pensando en otras etiologías, tal vez como el síndrome de Hughes, y eso realmente me encanta.
Foi muito interessante este caso e os pontos de aprendizado, como o Gabriel acabou de colocar em espanhol. Eu concordo com a Maria, esses scores nos ajudam muito a determinar a probabilidade de doença. Inclusive a Maria falou 72%, que é muito alto, e então nos direcionam para exames específicos para confirmar, porque ainda poderia ser outra coisa que se apresentasse dessa maneira, mas com essas calculadoras, e elas estão amplamente disponíveis para vários tipos de doença, a gente consegue direcionar e chega uma hora que a gente tem que parar de expandir o nosso diagnóstico diferencial e atacar a hipótese mais provável. Então, vou passar para você aí, Rafael.
Oh, incredible. I can't say incredible about Gabriel because I didn't understand the Spanish part, but I'm sure he was incredible. But thank you, Thiago. That was just brilliant. So, and thank you, and Mickey, for the case. Like, really, really interesting. Thank you, everyone who spent this afternoon with us. And thank you also, Maria, for facilitating and vouch describing. So we had a patient who altered mental status, and we thought about a mixed mnemonic, which includes metabolic causes, for example, hepatic encephalopathy, but also infection, especially pneumonia, UTI in an elderly patient, but also structural like subdural hemorrhage, toxins like opioid overdose or alcohol withdrawal. And then we tried to combine the mixed mnemonic with oncology, since this patient had this background of cancer. And we thought about, for example, infection, because most of the time this patient are going through chemotherapy, and that could lead to a status of immunocompromise. And also drug side effect, we thought about immune checkpoint inhibitor, but also metastases and hypercoagulability leading to stroke. We know that cancer itself can increase the risk of stroke due to hypercoagulability, but also pyrenoneoplastic syndrome in the case of a limbic encephalitis. And then we thought about an oncologic emergency like a neutropenic fever when the ANC is less than 500, and we have to think about causes like Pseudomonas. And then we discussed about the facial twitching, and we thought about tumoralized syndrome, which is another oncologic emergency that could be leading to hypocalcemia, and hypocalcemia could be leading to the facial twitching. Not only to hypocalcemia, but we discussed that it can lead to hyperkalemia, that could lead to arrhythmia, muscle weakness, but also hyperphosphatemia and hyperuricemia, and both could lead to AKI. And then another pearl that Ravi shared with us, that it's really important when we're dealing with a new patient, it's always great to review the list of medications. In this case, this patient had clonidine, clonazepam, garbalin, and those are very sedating, and we should try to modify those. And then we saw that this patient also had refractory hypertension. He had hypertension and tachycardia even with more than 2 antihypertensive drugs. And we thought about a pheochromocytoma, especially because he had this case of elevated metanephrines. And then we saw that this patient had on his labs anemia and thrombocytopenia. When we have anemia and thrombocytopenia, we have to exclude emergencies, including TTP, HUS, and GSC. And the 3 of them can lead to MAHA, with schistocytes on the blood smear. And then HUS and TTP, they can actually lead to AKI and the thrombocytopenia and the MAHA. And when we add fever and neurological symptoms, we have the tetrad of TTP. And then we excluded JC because in the set of JC, we have elevated GPT and PTT and decreased fibrinogen. And another clues to TTP was also the increased LDH and decreased haptoglobin and the elevated reticulocyte count. All of that were hints to the hemolysis that were going on with this patient. And then finally, which was the diagnosis, we talked about TTP, which is actually inhibition or deficiency of Adams S13, leading to large von Willebrand multimers production, and that leads to increased platelet aggregation, adhesion with microthrombi formation. And then we saw with MK that the food strategy is actually less than 10% of the cases. So thank you everyone, it was so much fun, and I hope to see everyone on Monday.